Hi, my name's Toby Hammond. I'm a colorectal and abdominal wall reconstruction surgeon at Broomford Hospital at the Mid-South Essex University Hospitals NHS Foundation Trust. An anal fistula is an abnormal communication between the inside of the anus and the skin of the buttock. It usually passes through a variable amount of the anal sphincter muscle. The anal sphincter muscle is essentially two rings of muscle that surround the anal canal and help us control the passage of stool and wind. The symptoms of an anal fistula tend to be either the persistent discharge of blood, pus and occasionally stool, or recurrent episodes of pain and swelling and abscess that will then either burst spontaneously or that you might need to attend hospital to have what's called an incision and drainage of the abscess to allow it to settle down. So I've been asked why people get anal fistulas. I think probably the first thing to say is anal fistulas occur in anywhere from 1 to 2 out of every 10,000 people, which might sound that that's not very many people, but actually when you look at the population as a whole, that's actually a huge number of people. And then why do they occur? There's actually a number of different causes for anal fistulas. However, probably 90% of them are what's known as idiopathic or cryptoglandular in nature. The remaining, and I'll talk about those shortly, the remaining 10% have very specific causes, with the most common one being a condition known as Crohn's disease. That's an inflammatory condition of the bowel. But you can also have conditions such as hidradenitis suppurativa, which is a chronic inflammatory condition of the skin. They can be caused by TB. They can be caused by cancer in some cases. They can be caused by radiotherapy. So there are a number of other causes that make up 10% of why we get them. Crohn's disease probably makes up the biggest number within that 10%, and the treatment for fistulas of specific causes like that is management of the underlying condition itself. The 90% of fistulas that are due to idiopathic or cryptoglandular reasons, well, they simply occur because within all of our bodies, around the anal canal, we have two rings of anal sphincter muscle, an inner ring and an outer ring. And these help us control our ability to hold on to stool and wind. So in between the anal sphincter muscles, we have something called intersphincteric anal glands, and they secrete a product known as mucin. And the mucin essentially reaches the anal canal because it passes from ducts, essentially tubing from the gland that passes through the sphincter muscle into the anal canal. However, for reasons we don't fully understand, bacteria can find their way up that tubing, that tract from the anal canal into the anal gland itself. And once the bacteria get into the anal gland, well, it's a very happy place for the bacteria because it's warm and it's mucousy, and they multiply, and they essentially will then go on to form an abscess. Now that abscess will build up within the intersphincteric space, and it will cause a lot of pain. And then that infection, that pus that's built up, has to go somewhere, and essentially it will then either burst back through the inner ring of muscle into the anal canal, it will pass down between the sphincter muscles to exit onto the skin around the anus, or it will pass through the outer sphincter muscle through the fat of the buttock and then find its way onto the skin of the buttock. There are other routes the pus can travel to make the situation more complex, but overall that's essentially what happens. And then once that abscess has burst its way through to the skin of the buttock or around the anus, that's known as a fistula because it's an abnormal connection between the inside of the anus and the skin of the buttock. And again, for reasons we don't fully understand, even once the abscess has been drained and all the pus is gone, in a proportion of patients, those tracts just don't heal and they persist. And it's those persistent tracts that are known as chronic anal fistulas. And these are the ones that will either persistently drain or intermittently get blocked, and more fluid would then build up and form an abscess, and that cycle of symptoms really begins. Once you're referred on to the hospital to see a specialist for what is thought to be an anal fistula, Then you'll have a consultation with the specialist in clinic, and they'll want to ask you a number of questions to understand how the fistula affects you and your quality of life. And they're going to want to know how often you open your bowels, what your stool consistency is like. They're going to want to know the symptoms that you're experiencing. They're going to want to know if you've had any anal surgery or any anal trauma in the past. They're going to need to know if you have any other medical conditions. And they're also going to want to know how your sphincter works. So are you able to comfortably hold on to wind and stool without any difficulties? And that will essentially formulate taking a clinical history. Then you're going to need a clinical examination to really assess the fistula and its relationship to the anal sphincters and the bottom. In some cases, the doctor that you're seeing may well recommend that you have an MRI scan. Again, this is imaging that helps delineate the relationship of the fistula to the anal sphincter complex and whether or not there are any complicating features that can impact on any treatment. And really once all that's done, then it's a case of looking at what treatment options are suitable and available for you, the fistula that you've got, and your sphincter function. And the treatment options will really vary depending on those factors. In general, the treatment options for a fistula will involve either doing nothing, so leaving matters as they are. That's always an option, but of course your symptoms won't improve, they will just continue. Then you can have an operation, and there are different kinds, or you can have an operation, I ought to say. So there are different kinds of operations that you can have. There is an operation called a fistulotomy, which is the lay open of the anal fistula. And this is a surgical procedure carried out under general anaesthetic, normally on a day case basis, which means you go home on the same day as the operation. And it essentially means surgically cutting all of the tissue enclosed by the fistular tract. Now this is an option that's been available for hundreds of years. It was actually originally described in I think 460 BC by Hippocrates. So things haven't moved on a hell of a lot in that time. But nonetheless, it's a highly successful treatment. It will cure over 90% of fistulas that are suitable to have that kind of operation. However, the trade-off for having the lay open of the anal fistula is that the surgeon is going to have to cut through the sphincter muscle that is enclosed by that fistula. Now, a lot of patients worry that if they have a fistulotomy, a lay open, that they're going to be incontinent to stool. And that's simply not the case, or hardly ever the case at all. You'd have to cut the entire sphincter muscle through in order for that to be the case. So generally speaking, as long as you leave behind enough good functioning sphincter muscle, then you're not going to be incontinent to stool. You're still going to be able to hold on to stool and go at a convenient time to you, but it may weaken the muscle a bit so that you may not be able to hold on to stool for quite as long as you once were. That's called fecal urgency. And you may have difficulty holding on to wind and also experiencing some low volume staining of your underwear because you can't hold on to those looser bits of stool that can occasionally seep down. So it's a really good surgical option, the fistulotomy. It will treat the fistula in the vast majority of cases, but the trade-off to that is that you may have some fecal urgency, some difficulty holding on to wind, and some occasional staining of your underwear afterwards. So that's one option. If that's not a suitable option, either for you as an individual or because your surgeon doesn't feel that's the right treatment option for you, then the alternative is to have what's called a sphincter preserving procedure. And there are a number of different operations that have been described over the years to try to heal anal fistulas without cutting any sphincter muscle and therefore having any of the problems that I described for fistulotomy. And there really are a huge number of them. So there are those operations that essentially separate the fistula tract from the anal canal. And within that, there are operations called an advancement flap or a lift procedure. A lift stands for ligation of the intersphincteric fistula tract. And there are things called over-the-scope clips that can be used as well to close off the fistula tract. Then there are other treatment options which simply involve putting fillers into the fistula tract, in an attempt to get it to heal. And people have looked at things like glue products and certain plugs to see if they work. And there's currently a treatment out there at the moment that's in its relative early stages where people are injecting stem cells into anal fistulas to see if that can heal them. There are treatments that essentially cauterize the inside of the fistula tract. So there's something called a FILAC, which is a laser treatment, and there's something called a video-assisted anal fistula tract treatment, which is when a small tube with a camera in it is passed into the fistula and it cauterizes the inside using diathermy, which is electrocautery. Essentially, those are the main treatment options available for trying to treat a fistula without damaging the sphincter muscle. Overall, the treatments that don't cut any sphincter muscle are probably successful in about 50 to 60% of patients. So this is a treatment option that's successful in 50 to 60% of patients, but won't damage any of the sphincter muscle. And if that treatment option doesn't work, it doesn't mean you couldn't then go on to have a fistulotomy, a lay open procedure, as previously described. If none of those treatments are suitable or appealing, then another option is not to try to treat and cure the fistula tract, but is to have something called a loose seton. Now, a seton is essentially a thread. It comes from the Latin seta, bristle, and literally it means putting a thread through the anal fistula tract. It doesn't cure it, it controls the symptoms, and it allows the fistula tract to continually drain, and therefore stopping fluid building up and causing an abscess. So in other words, it stops the abscesses, allows the fistula to continually drain, and that's its main function. And there are a number of patients who have these in place because their fistulas, for whatever reason, are too complex to be treated any other way. And by controlling the symptoms, actually it can give patients a much, much better quality of life than prior to having that particular seton. So I've been asked if there's any way in which you can prevent an anal fistula from happening. And actually the answer is no. The fistula didn't occur because you did anything wrong. It's not your fault in any shape or form. It is, unfortunately, simply bad luck. But once you've got the symptoms, I would strongly recommend that you go and see your GP so they can refer you on to a specialist. So hopefully those symptoms can be cured by one of the options mentioned earlier. One thing I would say though is that it has been shown that smoking can increase the risk of any treatment you have for your fistula not working. And therefore, if you are a smoker, it's far, far better for you and for the treatment of your fistula if you stop, so that any treatment that you receive can be as successful as possible.